now my wife, and we followed our favorite band around the country. They're called the String Cheese Incident from Netherlands, if anybody's ever heard of them. They're a whole lot of fun. But one of the stops on that tour was Red Rocks. And if you've ever been to a show there, it was just such an awesome experience that we just said, you know what, let's stay in Colorado. And we did. We've been here ever since. So we moved up to Breckenridge, actually, and did the ski bum thing for a couple of years, working for the resort. But I started to realize it'd be pretty easy to get sucked back into that lifestyle. So after 2 years, we moved down to the city, and I put my degree to work and everything that I had learned at a residential treatment facility for adolescents who were court ordered to be there in lieu of juvenile detention. It's a very tough population to work with, the adolescent justice involved folks. So I did that for 4 years, and I always make the joke that it was probably 3 years and 11 months too long. But after I finished doing that, I started working for Peer Assistance Services under the TASK contract, which was a contract with the Colorado Department of Corrections, working with adult parolees. So essentially someone would get out of prison and they'd come see me and their parole officer, and I would give them an assessment and get them referred to the appropriate level of care for substance use, mental health issues, and that sort of thing, and then follow them throughout that process. So I went on to strictly work with the gang unit. And I did that for about 5 years, and then that contract ended. And when it did, the company retained me, and I've been working with the SBIRT program ever since. And that's just over, I want to say just over 5 years at this point. So that brings us to today. So if I get a little passionate about this is why. I've certainly spent many years building up to where I'm at now. So I do just want to do a quick acknowledgement about my agency. Peer Assistance Services was founded in 1984, providing case management services for nurses who were suffering from substance use, mental health, or even physical issues that were preventing them from practicing within reasonable skill and safety. That's called our Peer Health Assistance Program, and it's actually since expanded to work with now nurses, pharmacists, dentists, veterinarians, the 6 mental health boards in Colorado, and emergency medical services personnel. So that's one half of our agency. The other half is our SBIRT program, which is what we're here to talk about today. So our agenda today is going to be to examine alcohol and health. We're going to spend more time on alcohol than anything else because there's decades of research behind it, and it still causes the most harm to society. But we are going to touch on marijuana and opioids. We're going to explore SBIRT for prevention of alcohol and drug problems, practice some skills, have some discussion, and then do a little bit of role play. I like these presentations and trainings to be pretty informal. So if anyone has any questions, feel free to type them into the chat box and I'll try to address them as they come in. Actually, let me pull the chat box open. Oh, someone said, yeah, string cheese. All right, Lisa. Okay, so feel free to type any questions into the chat box and I'll try to address them as we're moving forward. My colleague, Adam Muselowitz, is also here with us today. He's gonna help try to post a couple pertinent links into the chat box, and he's gonna be our patient when we do some role play practice. So, see if I can, whoops. Okay, so when we're looking at alcohol and public health, it's important to consider that excessive alcohol consumption is actually the 3rd leading cause of preventable death in the United States, falling only behind tobacco, which is still #1. It's been #1 for many, many years. And then #2 is what's called unhealthy lifestyle. So it's a combination of a lack of physical activity and an unhealthy diet. But that leaves excessive alcohol consumption as the 3rd leading cause of preventable death in the United States, which translates to about 93,296 deaths every single year. In Colorado alone, we see 5 deaths every single day due to excessive drinking. And one thing I want to mention about that is I did a training down in Canyon City before COVID hit, and someone from the county coroner's office was in attendance. And after I finished my training, he came up and we chatted a little bit. And he told me about how many bodies he sees come through where alcohol clearly played a role in their death, but it didn't get reported as such. And unfortunately, that's often where we get these numbers from, the death certificates, mortality reports, that sort of thing. But if alcohol wasn't explicitly listed as the cause of death, it didn't get reported as such. So 93,296 that we know of, how many more are not getting reported? But we see about 65.3 million adults that report having engaged in binge drinking in the last 30 days, and we'll talk about what binge drinking is here in just a minute. And 1 in 5 adults in Colorado report having engaged in that binge drinking. Nationally, we're spending almost $250 billion with a B dollars on economic costs. In the state of Colorado alone, we spend $5 billion every single year due to lost work productivity, healthcare costs, criminal justice, vehicle crashes, other things that arise as a result of alcohol use. Another thing I want to mention about that number actually is that comes from the Centers for Disease Control from 2010 data. They don't have any data beyond that. Just between 2014 and 2018, so in that 4-year period, the amount of people that moved into the state of Colorado was equal to the population of Denver. So just in that 4-year period, we essentially added another Denver's worth of population to this state. So I would imagine that over the last 11 years, that number has increased significantly. Another thing to keep in mind that's interesting to me is that 2014, when we started to see that surge of people, coincides with legalization of marijuana. So something to keep in mind there. Okay, so why else should we be screening for alcohol in healthcare? We know that alcohol use is associated with about 10 different types of cancer. Breast cancer has been the scariest. In my opinion, there have been studies that have shown that even less than 1 drink per day can increase the risk for breast cancer. We also know that it can increase the risk for accidents, injuries, falls, particularly in the elderly, which is a population that sometimes goes underserved, I think, when it comes to alcohol consumption. We know that it can increase the risk for STIs and poor pregnancy outcomes that we'll talk about here in just a minute. And then about 1/3 of the suicides that we see in the state of Colorado, alcohol was present at the time of death. We know that it's a major depressant and it can really wreak havoc on someone's mental health. We also know that it can cause some negative medication interactions, causing medication not to work, or sometimes it can even be fatal. It can cause fatty liver, cirrhosis, cardiomyopathy, pancreatitis, FASDs. Folks, this list goes on and on and on to about 300 different physical ailments that alcohol is directly linked to. These are just a couple of things that I've chosen to highlight. And if someone's already suffering from a chronic condition, alcohol can absolutely exacerbate it and make it worse. So hypertension, diabetes is a big one. Alcohol really messes with the glucose levels. Again, alcohol is a major depressant, so it can certainly have an effect on someone's depression and anxiety. Insomnia is another really big one. You know, people say that alcohol helps them get to sleep, and that may be the case, but it actually affects their long-term sleep in the long run and doesn't allow them to get that quality, restful REM sleep. It's particularly detrimental on the GI tract. It can worsen atrial fibrillation, and weight gain is another big one. The caloric content of alcohol is actually pretty high. So when we're talking with our patients about how much they're drinking, we want to give them this information about what's called the lower risk drink limits. So we can't say low risk, we have to say lower, because alcohol is an identified toxin, and over time it can be toxic to cells. So there's really no safe level of alcohol consumption. But the Centers for Disease Control have determined that if you stay within these limits, you're at less of a risk for developing some of those negative health consequences that I just talked about that can arise from excessive alcohol consumption. So those limits are no more than 3 per day for women and no more than 7 in a week. And then for men, no more than 4 in a day and no more than 14 in a week. And then as men turn age 65, they become a little more susceptible to the effects. So they go down to those women's limits. So I just want to pause there. I'm curious if any of you might be able to tell me why there's that disparity between men and women, if anybody has any thoughts on that. Why those numbers look a little bit different. And if not, that's okay. I'll just tell you. So on average, women weigh less than men, but alcohol is also dispersed through body water, and women have less of that body water that dilutes and breaks down that alcohol. But women were also born with fewer of the key enzymes called alcohol dehydrogenase that actually break down and metabolize alcohol. So that's why those numbers look a little bit different. And all of this being said, I also want to caveat that with the newest US dietary guidelines of 2020 actually recommend that men and women have no more than 1 drink per day on average. So it's putting men and women on equal planes, but the Centers for Disease Control hasn't quite caught up with that. Another thing I want to mention is that when I say men and women, I'm talking about sex assigned at birth. there's not a whole lot of data out there related to hormone therapy or the transgender population or anything like that. So hopefully later on down the road, we'll have that data. But as of right now, when I say men and women, I'm talking about sex assigned at birth. Okay, so what even is one drink? It's important to distinguish this with our patients because you know, we know that only about 1 in 6 people have ever spoken with their healthcare provider about their alcohol use. So it's really important that we describe all of this information and really kind of get them up to speed with all of the data. So a standard drink size in the United States is 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of liquor. Each of these contain about 14 grams of alcohol, but that beer that you're looking at right there is pretty much a standard Coors Light. In the state of Colorado, we are like the craft beer mecca. Before we became the marijuana mecca, we were the craft beer mecca. And so that's another thing to be, to define with your patients, because are they having that standard Coors Light, or are they having a craft beer, a microbrew that could actually equal 3 or 4 times that alcohol content? So that's another thing that we want to make sure that we're distinguishing with our patients. I always make the joke that I've probably done 250 of these trainings, and no matter what I do, that glass of wine still looks short to me. So that's another thing we want to explain to our patients. Are they having 5 ounces? Are they having a full glass, a full bottle? What's the case? I think if you go to a restaurant, they only serve them in 6 and 9 ounce pours. So that's another thing to consider. We're already drinking above that standard drink size if you just go out and order a glass of wine. And the same sort of thing can be said about liquor. If you get a bottle and you're making your own mixed drinks, it's not like anybody's sitting there measuring out 1.5 ounces. Same thing at a bar. So we just want to distinguish this so that they know what we're talking about when we say a standard drink. Okay, so there's 4 main ways that we define unhealthy or excessive drinking in the United States. The first type is binge drinking, up in the top left-hand corner there. And for women, that's considered as having 4 or more drinks on one occasion. And for men, 5 or more drinks on one occasion. And an occasion is listed as being about 2 to 3 hours. And the way they came up with that is they took the amount of time it takes an average person of average height and average weight to reach a 0.08 blood alcohol content. So that's where they got those numbers from. The second type is down in the bottom right-hand corner there, and that's heavy drinking. So for women, heavy drinking is considered as having 8 or more per week. And for men, it's considered as having 15 or more per week. The next type is up in the top right-hand corner there. Any alcohol used by those under age 21. As we know, the human brain isn't necessarily fully developed until around age 25. So to be honest, I'd like to say 25, but the law says 21. So if we can at least make it there, hopefully the outcomes are going to be a little bit better. There's a lot going on in an adolescent's brain during this crucial stage of development. I won't get into all that right now because we're here to talk about the other way that we define unhealthy drinking, which is any alcohol use by those who are pregnant. Now, I hear some rumblings of there still being some debate amongst clinicians when it comes to heart health and the benefits of alcohol. I actually recently just learned that that healthy part of alcohol on the heart actually comes from a piece that's in the skin of a grape. So it's not actually the alcohol itself, it's just what created the alcohol essentially. But when it comes to alcohol in pregnancy, there's no debate. Fetal alcohol spectrum disorders are 100% preventable. They're also 100% irreversible. So there's just no safe level of alcohol consumption for a woman who's pregnant. Okay, any questions on alcohol stuff so far? Okay, well, if anything comes up, feel free to type it in the chat box. So let's talk a little bit about marijuana. When we talk with patients about marijuana, I think it's important that we're truthful with them. And that truth is basically that we just don't know all that much about it. There's research gaps because it's still federally listed as a Schedule I narcotic, which, believe it or not, is a worse classification than both cocaine and methamphetamine. There are research gaps because even in the same strain of marijuana, there can be different levels of potency based on growing conditions and that sort of thing. And then there's research gaps because it's really hard to get a baseline on somebody. So because it's federally illegal, researchers have a really tough time saying, come in, use this marijuana, and we're going to study you. So essentially what they're saying is go home, use some marijuana, and then come in and we'll study you. And people are using different potency levels and strains and that sort of thing. So it's just really hard to get a baseline on somebody. But some of the stuff we do know, we know that it's associated with decreased lung capacity, cough, chronic bronchitis, frequent colds. Obviously, inhaling anything into your lungs that isn't clean air can be detrimental to your health. We also know that it's associated with increased heart rate and blood pressure. It's associated with memory and cognition impairment. Things like depression, anxiety, motivation have all been shown to get better after cessation of marijuana. And Val just posted a link to some marijuana resources in there. We've also got some on our website, sbirtcolorado.org. That Responsibility Grows Here campaign is still going on. I'm not sure for how much longer, but it's got a lot of helpful information as well. Another thing that we're starting to see a lot of increased cases of is this disorder called scromiting. And scromiting is a combination of screaming and vomiting, but the technical term for it is cannabinoid hyperemesis syndrome. Essentially what we're seeing is uncontrollable cyclic vomiting in heavy marijuana users. And there's cases of people who have been using marijuana since the 70s that this is just now happening to, people who have only been using marijuana for 6 months that this is just now happening to. So we don't really know what it is that's causing it from marijuana, this uncontrollable cyclic vomiting. I've seen studies that have tried to link it to pesticides. I've seen studies that have tried to link it to higher concentrations of marijuana. But we don't really know what it is that's causing it. But it's a super interesting disorder, and it can sometimes be difficult to get through to patients who say, I've been smoking since the 70s. There's no way this is a real thing and it's happening to me. But the marijuana that's been being smoked today is very different than the marijuana that was smoked in the 70s. Just between 1985 and 2010, the potency levels increased by about 15%. Since it was legalized in 2014, potency levels have gone up by about 3% every year. So we've actually never seen marijuana at these levels before. We don't really know what it's doing to the human brain, and it's going to take a lot more data before we have that, or a lot more studies before we have that concrete data. Another thing I do want to mention is that Dr. Turpin talked about it a little bit, that active compound in marijuana that causes that psychoactive feeling, that high feeling, is called delta-9 tetrahydrocannabinol. We just call it THC. It's one of many compounds in marijuana. We also know a lot about CBD, CBN, CBG, a few other ones, amongst a host of others that we don't have all that much information about yet. But that delta-9 tetrahydrocannabinol is what causes that high feeling. So in the state of Colorado, you can get a DUI doing just about anything, and you can get a DUI for being under the influence of marijuana. And there's several different ways that you can test for that delta-9 tetrahydrocannabinol. There's urinalysis screen, there's mouth swabs, there's hair follicle tests, there's umbilical cord tests. But the way that the government has chosen to test for it when it comes to driving under the influence is in the bloodstream. And there was a House bill that came out in 2017 that determined the cutoff level of what's going to constitute as driving under the influence of marijuana. And they determined that cutoff level is 5 nanograms per milliliter of active delta-9 tetrahydrocannabinol in the blood. Now, right after they came out with that number, there was a news station down in Denver that did a study where they took several heavy marijuana users and they had them stop using. A week later, they took their blood and each one of them was still at least 3 times that legal limit. So there's still some legal implications, even if a person says they haven't used in a few weeks. If they were a heavy marijuana user before that, there's still some implications of receiving a DUI. There's also legal implications with the fact that you have to be 21 years of age to use recreationally in this state and 18 years of age to use medically. So if you're under that age, you can still receive a minor in possession charge. Now, when it comes to marijuana pregnancy and breastfeeding, there's not really any human research connecting marijuana use to the chance of miscarriage, but there have been some animal studies that indicate that the risk increases if marijuana is used early in pregnancy. There have been a few associations found between marijuana use and pregnancy and future developmental and hyperactivity disorders in the children. There's also some evidence related to an earlier onset of psychosis in the child. When it comes to marijuana use by pregnant women and low birth weight, there's some mixed evidence out there, so we don't really have concrete data on that yet. But when it comes to breastfeeding, we know that moderate amounts of THC and all other cannabinoids, except for that CBN that I mentioned, can find their way into breast milk when a nursing mother continues to use marijuana. And I actually just recently saw a study that said that marijuana can stick around for up to 6 weeks after use. So it's recommended by the American College of OB/GYN not to use any marijuana while pregnant. So I wish I had a whole lot more data to give you. The bottom line is we don't know all that much about it. But there are some talking points that we can have with our patients, especially when it comes to pregnancy and marijuana. One other thing I want to mention, because I get this comment all the time, is that I'm not here to do the smear campaign and scare tactics on marijuana, because we have seen some good come out of it. We've collected $10 billion as a state. I've seen people able to wean themselves off of opiates by using marijuana, people who have been able to control pain and seizures and that sort of thing. So I don't want to, throw all these scare tactics out there. I just basically am here to say that we don't have enough evidence yet to say that the benefits outweigh the harms or vice versa. So this is still a pretty big unknown. But I urge you to check out some of those resources that were posted in the chat box. They can give you a little bit more information on marijuana. Any questions? I must be doing an awesome job then. Hopefully you're all still with me. Let's do a little dance break. Wake up. Feeling good? All right. Great. Okay, so opiate use in pregnancy. I do just want to touch on this. I'm not going to spend a whole lot of time on it because I think that you guys are experts when it comes to this sort of thing. But we do know that accidental overdose is the second leading cause of maternal mortality in the state of Colorado. We also know that it's associated with poor fetal growth, premature birth, potential for stillbirth, birth defects. It can add length onto the hospital stay and increase rehospitalization. And then there can also be withdrawal in the womb, and which can lead to neonatal abstinence syndrome. And I'll just let you read all of those indicators of neonatal abstinence syndrome. So I'm going to make sure that Katie and Val all have copies of the slides so that you guys can have this information later on if you need some talking points to talk with your patient about. Let's see, one question came through. What do we do with moms that use marijuana and breastfeed? We recommend that they don't breastfeed if they're going to use marijuana. Obviously, we can't be there to hold their hand. We can't be there to force anything. What they choose to do, what they decide to do is up to them. But we can give them that information that there have been some studies linked to, some of that developmental delays and hyperactivity later on in that adolescent's life for early childhood exposure like that. So we recommend no use during breastfeeding, or not breastfeeding if you're going to use. Okay, so these are just a couple of really powerful quotes. The first one comes from the Center on Addiction, and it says, every year that substance use is delayed during the period of adolescent brain development, the risk of addiction decreases. The second one comes from John Knight. He's the founder and director for the Center for Adolescent Substance Abuse Research, or CSAR, up at Boston Children's Hospital. They're sort of leading the pack when it comes to adolescent substance use research. And his says, addiction's a pediatric disease. There's so much going on in an adolescent's brain during this crucial stage of development where if they start using substances, a lot of times there's changes that can come from that substance use can be permanent, unfortunately, because it's such a crucial stage of development. So very important that we delay any initiation into substance use till a minimum of age 21. So some of you may be familiar with the ACEs study. The ACEs study essentially just went on to show that early childhood trauma is related to health and well-being problems later on in life, including early death. If you're interested in that, I would recommend checking out some trauma-informed care classes. There's a lot of really good information out there. But that slide in conjunction with this slide, this is the framework that we sort of look at addiction with these days. These are the 3 primary reinforcement factors that can contribute to vulnerability to developing a substance use disorder. Both of those 2 slides are what I want to get across essentially is that there's a lot going on in people's lives that can contribute to why they're using substances. We went on for this long period of time where people just said, It's a choice. You made the choice to start using, make the choice to stop using, and so on and so on. But really, there's a lot going on in people's lives that can contribute to why they're using substances. And ultimately, if we don't address some of those underlying causes, even if we have the person stop using substances, there's that potential to go back to using them if we're not addressing some of those underlying causes. So just something to keep in mind as when we're moving forward with this. Okay, so what even is SBIRT? SBIRT stands for Screening and Brief Intervention and Referral to Treatment. It's been given a grade B recommendation by the United States Preventive Services Task Force in regards to screening, brief intervention in adults for alcohol. When it comes to screening, brief intervention in adolescents for alcohol and other substances, it's been given a grade I recommendation, which stands for insufficient evidence. And I think the reason that we see that is because much of the research for SBIRT comes from primary care, but a lot of the areas that they have chosen to focus on for study have been like school-based health centers and those sort of settings. So I think over time, as we shift that area of focus, it's going to shoot up to that same grade B recommendation. And that being said, it's still recommended by the American Academy of Pediatrics, as well as the CDC, the VA, American College of Surgeons, American Colleges of OBGYN, American Academy of Family Physicians, SAMHSA, Medicare, Medicaid, et cetera, et cetera. So many large organizations backing it. Now that screening, that grade B recommendation essentially means offer routinely. What they're saying is they've found enough evidence to say that there's no harm and it actually is doing some good. So that grade B recommendation extends to screening, brief intervention in adults for alcohol and also for other illicit substances, but only those other illicit substances if there are processes in place to address that use. Okay, so this slide is essentially just meant to show that really anybody on the healthcare team can play a role in this process. Front desk staff can administer the screening form that can be interpreted by any number of healthcare providers. And then the brief intervention can be delivered by any number of healthcare providers. And if it's deemed that a referral to treatment is going to be necessary, that sort of coordination can be done by any number of healthcare providers. If you really want to sit down and talk about who's going to do what at your site, we're here to help. Just let us know and we're happy to sit down and really work on that process mapping or that workflow with you. Okay, I feel like I need to ask if there's any questions. If not, that's okay. I really just wanted to take a drink of water, so. Okay, so that brings us to screening. This is one pathway that we've laid down for screening. So you'll notice in the very first box there that, first of all, we want all patients to be completing these screening tools, but it's sort of up to you all what screening tools you want to use. Oftentimes screening is a two-step process where we'll start with a brief screen, and if that's positive, move on to a further screening. Like I said, this is just one method that we've chosen to highlight, but again, if this is another area where you and your site want to kind of sit down and talk about exactly what screening tool is going to work best for you, we are happy to help with that. But the pathway that we've laid down is using what's called the audit C+2. And then if that's positive, then we'd want to move on to a further screening using the audit, the DAST, or the QDIT. And I'm going to talk about each one of these briefly here coming up next. And then of course, after that further screening has been done, we're going to want to give the brief intervention, and we're going to go over that as well. So this is what the audit C+2 screening pre-screen form looks like. The first three questions address alcohol use. And so if you look on the left side of the screen there, it says if that's a positive question 1, 2, or 3, then you want to move on to the audit, which is the alcohol use disorders identification test. I'm going to show that in just a second. Question number 4 addresses marijuana use. So if that's positive, we recommend using what's called the QDIT, which is the cannabis use disorders identification test. And then number 5 addresses other illicit substances. Illegal drugs or prescription medications for non-medical reasons is how they have it worded. And then if that's positive, we recommend using what's called the DAST, which is the drug abuse screening test. There's a couple of really popular ones when it comes to adolescents. The CRAFT is the most widely used. And I'll show that, I believe, here coming up in just a second as well. So this is the audit. Again, it stands for Alcohol Use Disorders Identification Test. It was developed for primary care, but can be really used in a variety of settings. It'll identify risk level. And we have found over time that self-administering these screening forms, no matter what the screening form you choose to use is, will yield potentially more accurate results. And I think that part of that comes from patients feeling a higher level of comfort when they're just filling a screening form out on their own than they would if a clinician was standing there asking the questions. Now that can still be done. You can still do it that way. But we've just found that the results are potentially more accurate if they've done it on their own. This screening form is also available in the public domain. It's available in multiple languages and validated for several populations. So it's a pretty good screening form. The Cannabis Use Disorders Identification Test, or CUDIT, is used to address cannabis use. This is not really meant to diagnose anyone with a cannabis use disorder, but more so to open up the dialogue between you and the patient, and then for you to kind of use your clinical judgment to determine sort of where they sit when it comes to cannabis use disorder. I already talked a little bit about how it's just sort of a big unknown when it comes to cannabis use. So there's a lot of clinical judgment that comes into play when we're talking about marijuana. This is what the DASH looks like. Drug abuse screening test. Again, this is what we recommend using for other substances. Now, another thing I just want to mention is that there's 1 million validated screening tools out there. There's some that are specific to the perinatal population that you all are working with. There's pros and cons to every single screening form that are out there. There's one called the Assist that's like 30 questions long, and it asks about all substances, but it gets a little redundant, and because of its length, patients tend to get turned off a little bit, but it captures everything. There's one called the Cage that's only 4 questions. Patients love it because they're in and out. It's just 4 quick questions, but it doesn't capture quite everything. So ultimately, this is going to come down to what you and your site feel is best. And again, that's something that we're happy to talk with you about on a one-on-one basis. So this is what the craft looks like. You'll notice that this one's for adolescents. You'll notice that each question down at the bottom there, on the bottom left, CRAFFT corresponds to a word in the question. So the first one is, have you ever ridden in a car with someone who was high or had been using alcohol or drugs? R is, have you ever used alcohol or drugs to relax? The A is for alone, and so on and so on. And then on the right side is the back side of that screening form, and it's just kind of a scoring guide for your reference. And again, here to help any questions you have on that stuff. But I did sort of breeze through that section. So as I take another drink of water here, are there any questions? Okie dokie. Well, that brings us to the brief intervention section, and I'd like to have Katie or Val break us off into some breakout rooms. Adam, would you mind posting these questions into the chat box for me? Because for some reason, when you go into breakout rooms, the slide won't go with you. So Adam's posted the questions into the chat box there, so make sure you pull it from there. But there's two roles, the speaker and the listener. Now it says on there that the speaker is to pick a real life change issue, but I need to kind of throw a disclaimer out there that it's up to you all how serious you want to get with this. I've had groups that have said things like, I spend too much money on shoes, or I want to drink less coffee. And then other groups that have picked a real life change issue and they were all crying by the end of it. So it is up to you all how serious you want to get with this. But pick something in your life you wouldn't mind changing. The person who's playing the listener, it's very important that they don't give any advice, but they just ask these 4 questions. So why might you like to make a change in whatever the speaker chose? How might you go about changing it? What are the best reasons to change? And how will your life be different if you change? Then they want to reflect back, summarize everything that they heard, and just follow up with, so what do you think you'll do? So I'd like to take a few minutes and have you guys join some breakout rooms and do this, and then we'll come back and talk about it. So Katie, Val, whenever you're ready, throw them in the breakout rooms there.
Oops, I was on mute. I was saying they're open and let me know what time you want me to close them.
Okay.
We have 5 groups and they have like, most of them have 5 people in them. One has 4.
Okay. Yeah, we'll probably just give it like, let's see, we're at 11:40. Gosh, it's already been 40 minutes. We'll give them like 7 minutes if that works.
Yeah, sounds good.
Okay.
Yeah, I just have to close the room like a minute before we actually want them to come back.
Okay. 11:46, then you can close.
Will do. Sounds good.
I just noticed Megan Hazel is all alone, so I'm gonna go join her.
Thank you.
Kevin, what years did you live in Breckenridge?
05 to 07.
We barely missed each other. I lived in Breck from 09 to 13.
Oh, nice. Did you work for the resort?
No, I volunteered for the resort and got my pass that way. I would work due tour.
Okay,
and
cool.
Did it that way, but I worked at Mikasa and Gold Pan.
Nice. Mikasa is one of my favorite restaurants up there. Those duck quesadillas. Whoo,
So good. I lived
Okay.
off of them. I lived up there.
so good. Yeah, I volunteered for Copper to get my pass for that, but actually worked for Breck so I could have the pass for them as well.
Yeah, I waited tables and went to CMC up there, and it
Oh,
was
nice.
the best years of my life.
It sure was a lot of fun. It has doubled in size since I lived there. Everything's become exponentially more expensive.
Oh, yeah.
It was, I'm glad I did it. It was so much fun.
Ditto. When I was living up there, I remember complaining about $500 for rent, and now you wouldn't be able to find that anywhere.
You know, we paid $1,000 in 05 for an apartment that's probably the size of my pantry now.
Yeah.
In my house here now. But you know, you open the front door and it's $1 million view. It was right on Peak 8. It's called Val d'Isere, just up on French Street. I mean, it was unreal, so pretty. And then we moved into a house up on Peak 7.
Okay. I lived in Frisco, and then I lived directly across the street from CMC. It was like a roundhouse that was hanging off the side of the cliff, essentially. It's still there barely.
Nice.
And then I lived in Locals Lane, which is the French Creek area.
Yeah, okay, great. I like the French Creek area. I had some friends back there.
Good place. I had a great time.
Yeah, it sure was a lot of fun. I think I got 162 days of skiing in 1 year.
Wow.
But I mean, that was part of my job, you know.
Yeah.
But I always made sure to scan my pass just so I could get that day as counting.
Yeah, that recognition.
That's right.
Do you have like a home resort now, Kevin?
Honestly, Winter Park is sort of where I like to go, just because, you know, those other resorts, like Breck has gotten massive, Vail is massive. They've all got resort town feels.
Yeah.
Winter Park, the town is like off of, and honestly, Mary Jane is really my favorite mountain to ski. Because Winter Park, the town of Winter Park is like a little bit ways off the beaten path. Copper's also good because that's not really there's a couple of little areas, but some of these other places, you know, people go and they stay for a week on end, so it just gets crowded.
Agreed.
Loveland is also always fun. A Basin.
I have not skied in a long time because of COVID.
Yeah, I didn't go up at all this winter.
That's been my only activity this winter, has been snowboarding, because I'm already covered up and you don't really want to be around people anyways. So
Right.
it just fit in real well for me, because that's literally all I've done since there's no music. That would also be my other fun winter choice. So I've snowboarded. I think I'm at like 40 days right now.
Nice. Yeah,
So
the no music thing has really affected me. It's been nice.
I haven't looked. I saw Red Rocks is like gonna have music this summer, but I haven't looked at what they're doing because I guess it's gonna be restricted.
Yeah, there's 2,500 person capacity, and they've got, I looked at the seating chart today, they've got it separated into quarters.
Mm-hmm.
Allowed to leave your section while you're there.
Mm-hmm.
I mean, I'll still go. I'll do whatever I can to see live music. So
Yeah.
Feel you on that. Do what you got to do just to dance.
I actually like hate baseball, and I was like, hey, Worth, maybe we should go to a Rockies game, like just for the snacks.
yeah, sure.
Because like I don't care about baseball.
Baseball on TV is one of the most boring things ever.
Oh my God.
But going to a game is like, you know, get a hot dog and the whole.
Yeah. I was in Boston for grad school, and I went to 2 Red Sox games, and they were just fun. Like I didn't pay attention to the baseball at all, but it was just like a good energy.
Yeah.
And good snacks. But my aunts are like really big sports fans, and they watch golf and baseball on TV.
Horrible.
I'm like,
So
what?
boring.
How?
So boring.
Yeah,
That's
I
a
don't know how they do it.
Sleep.
Well,
So-
you know, I pay attention to live music the way a lot of people pay attention to sports.
There you go.
Tell you who the best pianist was from the Grateful Dead, but I can't tell you like the first baseman for I don't know any
I
team.
could tell you about all the snacks. That's what I bring to the table. By the way, the breakouts are closing in 31 seconds.
Great.
But yeah, I appreciate live music. Callie and I were just talking about like the people watching is so good too. Like when the deadheads all descend on Boulder.
Oh yeah.
The people watching. Next July 2022, we're getting married 4th of July weekend, and I wonder if the Dead are gonna play that weekend because it'll be like a very interesting confluence for.
It's been the weekend after that. I haven't missed Dead and Company in Boulder.
Oh, put us back. We're not
coming.
This activity always goes so fast.
Yes.
So quickly. So do we have everybody back?
Yep.
All right, great. So any thoughts on that activity? Anybody take anything away from it? What did you notice? Any thoughts at all?
I think you feel,
Go ahead.
I think you feel a little bit vulnerable sharing something very personal to people that you don't know very well. I'll just say that.
That's fair. That's a fair assessment. Absolutely.
And I was lucky enough to be paired up with Kaylin Klee, who I sort of know but don't know really well. And actually, it was a really nice thing. I wanted to talk to her some more. I was kind of mad when the session ended.
I'm texting Ann. I'm messaging you, Ann, right now too. I think that's kind of. I think it is hard to be vulnerable with people we don't know well, but I think sometimes if there's a silver lining of this past year is like now we just kind of all are a little more comfortable in these virtual spaces, and so we can. I appreciated Ann really just jumping in and going there. You know, I think we can. I think it's the message for me is like sometimes when we just give the space to each other to talk, we can be vulnerable.
I agree.
Yeah, absolutely. It can often be vulnerable topics, but the way that these questions are worded hopefully allows for some of that comfort to flow in. These are what are called open-ended questions. A closed-ended question is one that can be answered in a simple yes or no, a one-word answer type thing. But a closed-ended or open-ended question is one like these that kind of forces the person to delve a little bit deeper into their response. So hopefully by asking these 4 questions, you were able to uncover the person playing the patient or the speaker's desire, ability, reasons, and need for change. Because the more often they can hear themselves speak out loud about change, the more likely they are to achieve that change. So that's a perfect segue into the brief intervention or brief conversation portion of this. The framework that we've chosen to outline is what's called the brief negotiated interview. There's a few other frameworks that are endorsed by SAMHSA and other groups to do this, but we've found that this is the easiest and most comprehensive. So there's 4 steps to this brief negotiated interview: raise the subject, provide feedback, enhance motivation, and negotiate a plan and advise. And I'm going to talk a little bit more about each one of these steps. So step 1 is to raise the subject, and it's as simple as just asking a question. Would you mind taking a few minutes to talk with me about your screening results? When we ask permission for this, we put all the power into the patient's hands. We really encourage autonomy and sort of let them know that they're driving this train, which is what we want. We're just there to help them come to their own conclusions. Then we want to provide feedback. We want to review their reported alcohol use and compare it to those lower risk drink limits that I talked about earlier. It's important to remember that any alcohol use by women who are pregnant is considered high risk alcohol use. So any alcohol whatsoever, we can compare it to those lower risk drink limits, but we also know that there's some health effects that can come from any alcohol use at any level during pregnancy. It says on there to connect alcohol to presenting concerns or risk for future health conditions. Obviously, if they are in the hospital because they are pregnant or giving birth, the future health conditions not only can affect them, but also the welfare of the child. It's okay for us to express our concern and advise for them to quit or cut back, but we don't want to give too much information because it's important to remember that feedback is different than health education. So we don't want to overwhelm the patient with too much information. So then step 3 would be to enhance their motivation. We want to start by assessing their importance or their readiness. And so we might ask on a scale of 0 to 10, where 0 is you're not ready to make a change and 10 is you're extremely ready. On a scale of 0 to 10, how ready are you to cut back on how much alcohol you drink, or how important is it to you to stop drinking? Then we'd want to respond with what makes you that number and not a lower number. So when we ask what makes you, let's say that the patient chose about a 3, which seems kind of on the surface fairly low and not, that motivated. But then if we say, well, what makes you a 3 and not a lower number like a 1 or a 2, then they have to stop and give us some information as to how they got to that. Whereas if we were to ask what makes you a 3 and not a 9 or a 10, then they might give us this long list of reasons why they don't need to cut back. But when we say what makes you a 3 and not a lower number, then they have to stop and think, well, I guess it's, I guess I'd like to make a change because I, want to make sure my child is healthy. I want to make sure that I'm present for them, and so on and so on. We want to get them speaking in favor of change. If they say that they're at about a 0, then we can assess their confidence. We can change up the phrasing and say, well, okay, well, on a scale of 0 to 10, how confident are you that if you did decide to make that change, you could do it? We can ask what's going to help them feel more confident, if there's anything that we can do. We really want to be genuine, reflective in our listening, and just open and passionate and connecting with this conversation. If they're showing low readiness, we can explore the pros and cons. So we can say, what do you like about your current level of drinking? And then what are some of the not so great things about your current level of drinking? And then summarize both sides. So, on one hand, you like the way it makes you feel, it helps you relax. But on the other hand, you've now got your child to think about, and you want to make sure that you're present for them. Then we could just say something like, so where does that leave you? Again, that's an open-ended question that kind of forces them to think a little bit more on it. These are just some framework questions you can use to explore some ambivalence. Why might you want to consider making a change in your alcohol or drug use? If you did decide to quit or cut back, how would you go about doing it? What are some of the best reasons you can think of to make a change? And then my personal favorite is this last one. How does your current alcohol use fit with what matters most to you in your life? In a lot of cases, that's going to be their child and their pregnancy and that sort of thing. So kind of gets them thinking how alcohol plays a role in that. And then the final step is the plan making stage. This is where you actually want them to come up with a plan. We can always say, what you decide to do is up to you as your healthcare provider or as your insert job title here. It's just my job to give you all the information. What steps could you take to make a change? And they might have some ideas right then and there. They might say, I'm going to have less of it around. I'm going to stop hanging out with certain people, et cetera, et cetera. But they also might not have any ideas. So it's okay for us to offer input. We just want to say, would you mind if I gave you a couple tips? Then you want to help them develop the plan. What kind of things are going to be challenging? How are they going to approach it? How can we help? And then summarize it all. So your plan and your next steps are you're going to do A, B, and C to decrease your alcohol consumption so that you're not risking yourself or the health of the child. I think that sounds like a great plan. Would you mind checking in with me in a couple weeks? If you're not typically in a position where you see the patient, it's okay to put that on their primary care physician, so the next time they see them that they can bring it up. And then we just want to thank them. Appreciate you having this conversation with me. That closes the loop on when we asked permission in the first place, and it re-encourages that autonomy. We want to make sure we're addressing stigma throughout this whole process. A lot of people can feel like this is coming out of left field. I'm not here to talk about my alcohol use. Why are you asking me these questions? Well, we want to try to normalize it. Just like you get your blood pressure taken, your oxygen levels, your temperature, that sort of thing. We're also going to ask you questions about your substance use. So we look at it as a vital sign. It's a part of your overall well-being. We also want to make sure, be very aware of our language and make sure that we're using person-first language and avoid terms like junkie and addict and alcoholic. When we say things like alcoholic, we create black or white thinking where you're either an alcoholic or you're not an alcoholic, but really substance use is on a spectrum and anyone can be anywhere on that spectrum. One of the most powerful quotes I've heard on this is, we don't call people who are suffering from cancer, we don't call them like a cancerous or something like that. So let's not call people who are suffering from an alcohol use or substance use disorder an alcoholic or an addict. You can check out that website there. The Addictionary kind of gives you most up-to-date terms, but keep in mind that language is a moving target and it's constantly evolving and changing. Okay, the referral to treatment piece. Who's going to need a referral to treatment? These are going to be folks who have, their screening form has indicated a need for it. They might be showing a pattern of binge drinking, have seen some consequences and keep using despite those consequences. And they might have even tried to quit or cut back and have been unsuccessful. We always just want to make sure that this is a shared decision-making collaborative process. There's so many different types of treatments that are out there. You don't need to know what type of treatment they need to go into. You need to know someone that you can refer them to who can make that decision. But we want to make sure that we're working in conjunction with the patient on this. For example, if your patient has identified themselves as an atheist, let's not send them to a faith-based counseling center. That's probably not going to work for them. But adversely, if they have, if they heavily rely on their faith, that's probably what we want to do, because we want them to get something out of this. We don't want to just have them go somewhere and feel like they're forced to be there. We really want them to learn. If you have Medicaid patients, you can check out that website. They sort of serve as the point person, the care coordinator. A lot of really cool resources on there. I recommend checking that out. There's also a couple treatment locators. The Office of Behavioral Health has developed Colorado Ladders, which does the same thing as the SAMHSA treatment locator, but a smaller breadth, just in the statewide versus nationally. Essentially just asks you to plug in your parameters. So the area of the state, the type of treatment they need, how they're going to be able to pay, et cetera, and it will narrow it down to what's available in the area. So really cool website to check out. Okay, now I want to watch a demonstration of this. And I think I have it queued up here. Yep. And just give me a thumbs up in the chat box or something. Let me know that you can hear it and see it, and that would be helpful.
Screening, brief intervention, and referral to treatment, or SBIRT for short, is an evidence-based, integrated, and comprehensive approach to the identification, intervention, and treatment via referral for substance use, domestic violence, depression, and tobacco use. Starting the conversation, engaging the patient, and knowing how to guide women in our care is the key to success. This presentation is provided to assist healthcare workers in conducting screening activities designed to identify women with disorders associated with opioids or other drugs and associated behaviors that can have an impact on prenatal and infant health.
Screening does not take long and can easily be part of your routine patient assessments. Screening questions are best delivered in a conversation with your patient using a validated tool. It is important to stress with patients that these questions are asked of all pregnant women as part of their care, and that the purpose is to identify the need for additional services. The Florida Perinatal Quality Collaborative recommends 3 validated screening tools, which can include the NIDA Quick Screen, the 5 Ps, or for adolescents and young adults, the CRAFT. All 3 can be found on the FPQC website.
According to a recent study, using SBIRT can improve adult access to preventative ambulatory health services, improved timeliness, frequency, and adequacy of prenatal care, and improved timeliness of postpartum care. This is a scene that takes place in my practice frequently. Good morning, Helena. How are you doing today?
I'm good. How are you?
Doing well, thank you for asking. I just talked to Margot, the physician assistant, and she said that your baby's measuring perfectly, that the ultrasound looks good, and all your lab work came back normal. So you must be doing something right. That's awesome. She did say that there were some of the questions in her screen that merited to talk to you a little bit more about some medications. Can you tell me a little bit about what your concerns are?
It's really scary.
It's okay. We're not judging.
I've been taking Dilaudids. I've been taking Xanax.
Okay. Are they prescribed to you?
The Xanax is, but not the Dilaudids.
Okay. And how long have you been doing that?
About 15 years.
Okay. And you weren't comfortable bringing that up at the beginning of your pregnancy care?
I thought I could stop.
And that's completely understandable. A lot of women who aren't able to stop when they're not pregnant can find the strength to stop, or at least want to stop during pregnancy. So I understand that, and you probably were frightened to bring it up. You didn't know if you wouldn't be able to get prenatal care with us, or if you would be reported. There's a lot of reasons people are frightened to let us know, and it's really brave that you did so. Thank you for letting us know. Any other medications or substances at this time?
No.
Okay, no tobacco, no alcohol, no marijuana?
No.
Okay. And have you been having to engage in any risky behaviors to afford the Dilaudid and the needles?
No.
Good. I'm glad to hear that. Are you in a safe situation at home? Do you have a boyfriend, a mom?
My mom is really supportive.
Okay.
I do have a boyfriend, and I stay with him at his mom's house when she's not home.
Okay.
But I can't stay at my mom's house.
Does she know about the history of drug use?
A little bit.
Okay. So it's not a secure, safe place for you to be with her. It doesn't work out. So when you're not with your boyfriend or at his mother's house, where are you staying?
I stay in my car.
Okay. That must be really hard and frightening to manage that and a job and then coming here to get prenatal care. You've got a lot of resilience. You have a lot of coping mechanisms. You're working right now?
Yes.
Okay, so you're able to afford food and normal things that you need day to day, but it's not a stable environment that you're living in right now.
I have WIC and I have food stamps to help me with food.
And the use that began 15 years ago, did you have any issues of depression or trauma that precipitated starting to use?
I definitely used to just party with my friends, and then it got a lot worse, and I seem to be the only one still partying.
Okay. Well, that's an honest answer. And certainly it sounds like with counseling and maybe therapy, support therapy, we could find some reasons that you find that to be the case and how to help you get around that now. What would you like to see happen?
I just want to have a healthy baby.
And that's commendable. And I'd like to see you have a healthy baby and be healthy yourself and go on to do amazing things in the world. You definitely have potential and you're motivated, and I believe you can be a good mother. So available to you are services in our community that can help with both handling the addiction, either with abstinence-based therapy or with medication-based therapy. We can get you counseling and get you involved in classes that help you learn that this is a disease just like any other disease, hypertension, diabetes. It's no different to be a pregnant woman with these diseases than somebody who has a substance dependence that needs to be addressed. We just need to connect you to those services and make you know that we will not judge you. So what we'll do is we will get you in touch with the services available in our community for housing, for opioid use. Talk to the doctor that's giving you the Xanax, see if we can help with trauma-based therapy or other counseling, and continue your prenatal care with us so that at the end you're going to be able to have a healthy baby that you take home.
Okay, that sounds wonderful.
Well, we'll look forward to seeing you next week.
Thank you.
All right. So I had initially planned on us doing some practice, but I think we're down to like 10 minutes. Is that right? So I'm gonna just get through the rest of these slides and then open it up that I'm here if you want to practice these. There's also a resource in the back end of the slides that you'll all get a copy of that allows you to do some additional online training, which really lets you practice having these conversations. So really cool, worth checking that out. But that video comes from the Florida PQC, which was referred to me by Katie and Val. Awesome resource. Looks like Val posted the link in the chat box there. So take another look at it and see that this is not a painful process. It can be pretty quick and easy. And you can really, really approach it in a non-judgmental way. Okay, so I'm gonna skip past these. So I've already mentioned this a million times, but we offer continuing technical assistance. So as you begin to implement this SBIRT process, if you have questions about anything, workflow, how specific substances affect the population you're working with, you want to practice having some of these conversations, whatever you need help with, we are here to help. The SBIRT in Colorado team is here to help. Feel free to reach out to us and we're happy to take phone calls, emails, Zoom calls, whatever it is you need help with, we're here. So with that, I will just want to ask if there's any questions before I let Katie kind of run through the resources section. Oh, and I think there was a question Val had, let's see. Would you in this process elicit or offer suggestions, alternative ways to achieve the benefits, what they like about the behavior? Or does this delve too much into teaching? I think it's kind of an iffy area. We want to make sure that we're giving them the room and the tools to be able to come up with their reasons to change, their ways to change on their own. But if they're really having a tough time getting into this conversation, that's when it's okay to say, do you mind if I give you some information? And I know that can be very difficult to do because it's sort of ingrained in us as people, especially ones working in this field, that we just want to solve people's problems right then and there. We want to give them the answers. But it's more impactful and they're liable to take that information more at heart if they can come up with it on their own and then hear themselves sort of work through it and speak out loud about it. So the answer is kind of, if that makes sense. Any other questions?
This is Val. I was about to chat this, but it's faster to just say, given how difficult these conversations can be, we know that one single SBIRT training is not enough. So we do plan to revisit these conversations throughout the year, and we're working to try to engage patients with lived experience who regularly advocate in this space to kind of practice having those conversations and provide further guidance from the patient perspective.
Great. And yeah, I would recommend, I'll show you the resource here in just a minute, but I would recommend getting on and online and practicing the conversations through that online portal. They're really cool ways to practice. So Katie, do you want to talk about this slide at all?
Yeah, so we'll see how much time we have. Why don't you keep going and then I could
Okay.
always present this slide after lunch.
Okay, perfect. Okay, so this is an app that we have developed. It's part of our public awareness campaign. It's more for the general public, but you all as clinicians can get a lot out of this as well. We use this video game technology. to practice having these conversations. So if you look down in the bottom left-hand corner there, you see those 3 digital avatars. There's 3 conversations on here. The first one's with Jordan. He's using marijuana and it's starting to affect his job performance. So you actually role play as his coworker and kind of have just a real honest, open discussion about it. The second one is with Donna. She's a family member of yours. She's going through a divorce and starting to feel a lot more stressed out because of that. And so she's been drinking a lot to handle that stress. So you just have a conversation with her about other ways maybe to handle that stress. And then the last one is with Sienna. She's getting ready to go to her first high school party, and you actually role play as her father, who doesn't really know what to say. So there's 2 conversations there, one before the party and then another one afterward. Again, best for general public, but also really good for you all. Along that same vein, we've created one that's specific to women's health and alcohol, which I think you guys will get a lot of benefit out of. Even just giving it to patients who don't necessarily feel comfortable having this conversation in a clinical setting. They can just, download these apps for free and get a lot of information in the privacy of their own home. But you speak with Maria up in the top right corner there. She's a nurse, and she'll not only give a lot of information about how alcohol affects women differently than men, but also tell a few stories of some women she's worked with and how they were able to make some changes in their alcohol use and see some real benefits out of that. So available for free on the Google Play or App Store. You can also find it on our website, sbirtcolorado.org, and Adam posted a direct link in the chat box there. A lot of really cool stuff on our website. Not going to run through all this, but check it out, sbirtcolorado.org. There's a lot of really good stuff on there. We've got some printable resources. We can also provide physical copies of these. The one on the left is a poster. We call it our exam room poster. It kind of helps decrease some of that stigma by letting people know that we're not singling you out. We ask everyone these questions. It's a part of overall routine healthcare. The one on the right is a patient handout wallet card. It's pretty small, but they're really great to just give out to patients that say, here's what the lower risk drink limits are. Here's some reasons you should cut back or stop drinking. So really cool there. These are really helpful to use for you as clinicians, SBIRT pocket card sets. They've got the same kind of information on the front, but then on the back side are those 4 steps for the brief conversation that we talked about. Again, happy to send you all copies of these. Just reach out and let me know. We do have one that's specific to women of childbearing age, I think is how they titled it, but perfect for this population. So this is that online training that I mentioned. Same video game technology, same company that does it, but those apps were more geared towards general public. These are more geared towards you, and there are continuing education credits attached to a couple of these. So I recommend checking them out. They're really cool. You get a little additional training and some practice on how to do these. And then it's fun because if you say the wrong thing to the patient, a little thought bubble pops up next to their head and they kind of will let you know that you said the wrong thing. So really cool to practice having these conversations with. Some more information on marijuana. You can check out that printable booklet. I'm happy to send you some copies of those as well. And then this last section is just some additional information. I already kind of went over this one, a little bit more information on FASDs, some more opiate use in pregnancy, and just some additional information. So with that, I will again ask if there's any final thoughts or questions. If not, that's okay, but feel free to reach out to me if you have any.
Great. And if there are no questions, I can present this next slide. So we wanted to call attention to resources that you actually already have, but you might not know you have in your team resources folder. And again, you'll get these slides, so you'll have the links, but I just want to go through a couple things that are in here related to this. So Val just added in the link for the team resources folder, and within that folder, there are some subfolders. So in peer support resources, you'll find resources for connecting to peer support programs. So programs in your area that have peer navigators who have been through recovery and they're happy to connect with your team and be a referral resource when you have a patient with substance use disorder. And I will be connecting you each individually, your teams individually, to your local peer support resource anyway. But take a look at that. In referral resources and mapping, we have mental health specific resources, substance use disorder specific resources that you can use for referrals. And then we also have a worksheet in there that you can work on with your team so that you have what's called referral resource mapping, so that you have something to hand to your patients or the staff to have that says, okay, this is who we refer the person to for outpatient methadone treatment, et cetera, et cetera. In screening tools and SBIRT resources, we have those various tools that Kevin talked about, and we also have some of those pocket cards and promotional things that you can hang up. In patient education materials, we have some education for patients, like things you can hand them about opioid use in pregnancy, neonatal abstinence syndrome. And then lastly, in those language matters, stigma resources, some of that stuff that was mentioned earlier today, especially by Danielle this morning, about how we talk about addiction and how we talk about people who have addictions. So that is just some guides to help you shift your language. And with that, Kevin, if you could stop sharing your screen and then Val will share hers. We are going to lunch. We have a 30-minute break. We will come back at 12:45 p.m. So please be back. We'll start right at 12:45 and get into our afternoon session. If you can, please don't leave the Zoom. If you can stay on and mute yourself, stop your video. You can turn off the volume on your computer so you can't hear anything. But it's easier for us if you stay on the Zoom because we're going to be assigning you to afternoon breakouts. And that's about it. Feel free to put any questions in the chat or any ideas or thoughts that come to mind, and we'll be sure to address them at some point. But thank you so much to Kevin. You'll get all these slides. And like Kevin said, if you want to have individual SBIRT trainings with your team, please reach out to them because they can provide all sorts of trainings and technical assistance. Great. See you all at 12:45. Thanks, Kevin.